Hi, it is Hsuan-Yi Lee. I'm currently studying in the Nanchang University and majoring in clinical medicine. Today, I'm very glad to be here and to present you guys about my paper titled Current Options for the Treatment of Advanced or Metastatic NSCLC. As we have seen, the decline in lung cancer has accelerated, especially the survival rate of non-small cell lung cancer has increased rapidly. For example, NSCLC 2-year relative survival increased from 34% to 42% during 2009 through 2016. It is because of reductions in smoking and improvement in early detection and treatment. But the overall survival for stage 4 metastatic NSCLC remains less than 5%. We all know that chemotherapy is currently the primary treatment option for the patient with advanced cancer, but can be limited due to the severe side effects, so developing new therapies to overcome the disadvantage is required. The PD-1 receptor is mainly expressed on activity T cells, binding of PD-1 to its B7 family of ligands, PD-L1 or PD-L2, result in suppression of proliferation and immune response of T cells. Activation of PD-1 and PD-L1 signaling serves as a principal mechanism by which tumor evade antigen-specific T cell immunological responses. So checkpoint blocks reverse this process and enhance antitumor immune activity. With further researchers, many evidence showing that chemotherapy can reduce the proportion of T regulatory cells in peripheral blood and tumor microenvironment. Using chemotherapy on apoptotic tumor cells can increase tumor antigen presentation to T cells, further synergizing with immune checkpoint inhibitors. So combining PD-1 and PD-L1 immune checkpoint blocks with chemotherapy can result in a high level of immunological effect in specific population through synergistic mechanism. Thus, we focus on the FDA-approved registration trials of anti-PD-1 and PD-L1 combined chemotherapy for advanced or metastatic NSCLC. We summarized the immune-mediated adverse event and survival outcomes of different PD-L1 expression level in patients with NSCLC received PD-1 and PD-L1 checkpoint blocks in the table. Our study found that most of both clinical trials showed a more optimistic overall survival and progress-free survival than chemotherapy alone. This may be a promising treatment option for patients with advanced NSCLC expressing PD-L1 to prolong survival. Additionally, patients with higher expression of PD-L1 have a higher response rate after receiving atelemab combined with chemotherapy. So many experts believe that the level of molecular expression is related to the patient's response to antibodies. But this still needs more research to confirm. Even if there's more evidence to support this view, the molecular detection standard has not yet reached a unified clinical level, and there are still some facts that need to be overcome. Most patient subgroups in the primary analysis population treated with immunotherapy and had a improvement in OS versus chemotherapy. In the CheckMate 26, overall survival with nivolumab have similar to overall survival with chemotherapy, but nivolumab had a favorable safety profile as compared with chemotherapy. Imbalances in the characteristic of patient at the baseline may have favored the chemotherapy group, including disease characteristics that are associated with better prognosis. It makes the result difficult to identify. In patients with metastatic NSCLC, the addition of pembrolizumab to induction therapy with chemotherapy result in significantly longer survival and progression-free survival, and the higher responses rate than the addition of Pascal. This survival benefit for pembrolizumab combination therapy was observed across all categories of PD-L1 expression. IMpower 130 shows that the addition of atelemab to chemotherapy a significant and clinically meaningful improvement in overall survival and progression-free survival, with an acceptable safety profile in patients with stage 5 NSCLC, providing another treatment option for patients. In a MYSTIC study, patients with PD-L1 expression more than 25% have improved outcomes compared with PD-L1 expression lower than 25%, which indicate that molecular expression higher than 25% is an appropriate cutoff point for development therapy in NSCLC. Additionally, all grade treatment-related adverse events occurred in 14% of patients treated with durvalumab and 34.8% with chemotherapy. Another treatment is tyrosine kinase inhibitors. Different tyrosine kinase inhibitors have different ways of action, including competing with adenosine triphosphate, causing the conformation change of kinase through allosteric regulation and making tyrosine kinase unable to connect with traffirin, which leads to the ubiquitination and degradation of kinase. Tyrosine kinase acts as a switch of many signal transmission in cells, and the use of TKI can block this signal transmission. Driver mutations are essential for carcinogenesis and tumor progression because they confer the selective growth advantage for cancer cells. Identification of driver mutation in group-related protein kinase, especially tyrosine kinase, have led to clinical development of TKIs in NSCLC. Osimertinib shows good efficacy for recurrent or advanced NSCLC, but the drug resistance is a major problem. Some patients have initial resistance to EGFR TKIs, and most cases with effective treatment also have disease progression after the remission. However, most patients are still refractory to anti-PD-1 and PD-L1 therapy. Identifying the predictive biomarkers and design rational combination therapy become a priority in cancer immunotherapy. Second, driver gene mutation target therapy is a new trend in the treatment of lung cancer, but the benefit is limited by the drug resistance. A large number of studies have shown that EGFR TKI resistance involves multiple mechanisms. So it is the main task of lung cancer research to clarify different resistance mechanisms and carry out individualized treatment. First, although there is linear relationship between the size of the benefit of checkpoint inhibitors and the level of tumor PD-L1 expression in NSCLC, tumor responses have still been observed in those with low or undetectable PD-L1 expression. The threshold used to determine PD-L1 positivity for the different checkpoint blocks have been defined differently. The limited predictive value of this test represent a major limitation to the routine clinical use of PD-L1 assay. Although only subgroup of patients with specific driver gene mutations and PD-L1 expression may benefit from target therapy, genetic testing and lab testing may accurately identify the potential beneficiaries to enable personalization in NSCLC treatment. However, larger studies are still needed to further investigate its predictive value. The finding of this review could also provide information on more treatment options for advanced NSCLC. That's all that I want to say. Thank you, everyone.